commitment that they have shown. I also wanted to make sure our Chief Scientific Officer of Johnson & Johnson could not be here, unfortunately, due to some business critical issues, but he did make a video and wanted to share a video message with you. So if we could roll the videotape.
Distinguished panel members and guests, hello, my name is Paul Stoffels, Chief Scientific Officer at Johnson & Johnson. I was very much looking forward to joining you in person, but unfortunately, due to a business critical meeting, I'm not able to be there. I'm disappointed, but please know that I'm there in spirit. Johnson & Johnson Innovation is proud to be a significant sponsor of the next Einstein Forum Global Gathering to recognize the invaluable role African scientists, innovators, and entrepreneurs play in taking advantage of science and technology to address the most serious health challenges of our time. So, what do we see as the future of health? I believe that we should be bold and ambitious and aim high. At Johnson & Johnson, our goal is to make significant progress toward a world without disease by 2030. And if you combine that with the UN Sustainable Development Goals for 2030, you quickly realize that we need massive amounts of science, technology, engineering from all over the world, including Africa. We believe that only by bringing together the best new ideas and the best science from everywhere across the globe, we will achieve our 2030 goals. By working together, we can solve today's greatest medical challenges, from infectious disease like HIV, tuberculosis, Ebola, and Zika, to non-communicable diseases like cancer, hypertension, diabetes, and mental health. At Johnson & Johnson, we are looking for ideas to fuel life science and technology innovation wherever it exists, through our internal R&D, the J&J Innovation Centers, our J-Lab incubators, and through our numerous collaborations with partners all across the globe. And it's why we look forward to working with all of you to continue to foster talent and life science and technology innovation in Africa. On a personal note, I have a special connection with Africa because as a young medical doctor, I began my training in Africa at the very beginning of the HIV crisis. Since then, in spirit, I've never left Africa. I'm a believer that Africa's scientists will solve some of the biggest medical problems of our time. I'm inspired by the NEF Fellows and the promise and the potential of Africa that they demonstrate. I believe together we can address diseases along the entire spectrum of health, including prevention and diagnosis and cure. Again, it is a pleasure to support this initiative. Enjoy the meeting. I will miss you. Thank you.
So before we open up the session, the panel session, I wanted to just make a few closing remarks. First of all, thank you again to NEF for the NEF Champion Award. Really appreciate it. I also wanted to congratulate the NEF Fellows as well, and also the NEF Ambassadors for all the great work that they do. And then, of course, the NEF team, including Yusuf Traveli and Natalie, both of whom have just been instrumental in making this a huge success. Finally, I just want to say that all of us over the last 3 days have just been so inspired by the fantastic science and innovation that's happening here in Africa. But we need to do more in sort of bringing these stories to the globe, to all over the world. And that's why we launched the Champions of Science Storytelling Challenge, where we're calling on all scientists and innovators in Africa to showcase their work. And by amplifying the stories of scientific innovation taking place across the continent, we want to showcase the impact that it's having on families and communities all over the world. And we hope to build public engagement for the support of science and also for the support of Africa's young women and men to pursue careers in science and innovation. So I'll just leave you with an email address for submissions. If you yourself are a scientist, or if you know of one, please spread the word. It's Champions of Science, all one word, at IT, as in Tom, S as in Sam, .j, N as in Nancy, J.com. So again, it's Champions of Science at its.jnj.com. NEF.com. We hope to receive lots of stories of innovation from Africa. Thank you all very much.
Yes, you can stay. Thank you very much, Seema, for laying such a great foundation for the next panel discussion. To moderate the next panel discussion, I would like to call upon Dr. Nina Dudnik, founder and CEO of Seeding Labs. Dr. Nina, please come forward to introduce the panelists as well. Thank you.
Okay. Good afternoon, everybody. Thank you very much to everyone at NEF for inviting me to be part of this panel. The topic is ambitious, the future of health in Africa. Hopefully this is going to be a conversation that's a little different from the typical conversation about health in Africa. Typically we focus on urgent care, capital E epidemics like Ebola, and the more day-to-day urgency of things like chronic malaria. We also, unfortunately, often talk about technologies received, technologies developed somewhere else around the world. Not today. Today, we're going to discuss preventing disease before it strikes, developing a true culture of health and disease prevention. Today, we're going to discuss how to leverage new technologies, particularly technologies developed by African innovators for Africa, and to better understand disease, to detect diseases earlier, to enable preventative interventions, and even to enable interventions tailored to the specific individual patient. My hope is for this to be a very interactive conversation, including the audience, that we can talk about that balance between prevention and treatment, between low-tech and high-tech, and hopefully throw the challenge to you to provide specific recommendations for developing the skills, the infrastructure, and the policies that are necessary across different African environments to deploy all of these technologies and approaches. I'm going to introduce the panelists. I hope they'll come up, and forgive me for not listing all of their amazing qualifications. I encourage you not just to read about them in the program, but to look them all up online. I'd like to call up Dr. Agnes Binagwaho. She is the Vice Chancellor at the University of Global Health Equity. Dr. Kevin Dzobo, NEF Fellow and Senior Research Scientist at the International Center for Genetic Engineering and Biotechnology, and lecturer in the Department of Integrative Biomedical Sciences, University of Cape Town. Dr. Genya, Head of Precision Medicine at the Center for the Fourth Industrial Revolution, the World Economic Forum, and Tracey McNeill, CEO of babyl, Rwanda. All right. Fantastic. Dr. Binagwaho, I'm going to start with you to set the scene for us around predictive, preventative, and what's the third P? Personalized medicine. As the Minister of Health in Rwanda, you probably thought very much about the balance between prevention, treatment, prediction, personalized. Can you talk about sort of the push and pull between those in a setting like Rwanda?
Okay, so let's put things right. I'm no longer the minister since almost 2 years. But even when I was a clinician or a program manager, I think those three words are matter. First of all, predictive, you need to know what are the most expected disease or problem your client, your people are going to suffer, so that you can have the drugs in stock and the system to provide care. And it's important because I'm going to talk about what you say we will not talk about, Ebola. Ebola was absolutely predictable. Just look the publication since 1972, 1980, 1983. Ebola is an endemic country in the 3 countries that were the most affected. So if you don't predict, you are not prepared, you face a catastrophe. And to do that, use the scientific knowledge, use the data that are available, and be evidence-based. So there is no excuse for nobody, especially international organizations like WHO. For preventive, of course, it's better for all of us to have a healthy population. and even healthy clients, healthy families, healthy communities. For the people who are doing business here, you have healthy workers, the production is better, and also it's known that maybe it costs upfront a lot to prevent, but the outcome on the long run, it's cheaper to prevent. And personalized, having centered health services or system, it's very important because you can adapt what you do, and you lost less money in doing things wrongly when you know for who you do things. So this is brief and so short, but roughly you cannot create great program or great system without being individual, people-centered, without prediction of what you may expect, and without wanting to prevent the disease they will face.
Thank you. Can you talk a little bit, one of your big innovations here was a massive workforce of community health workers. But you then, which is a fairly, I would guess, low-tech in its way, kind of a solution, right? But then you did actually arm them with technology like an SMS-based reporting system. Can you talk a little bit about that?
So first of all, low-tech, high-tech, just count how many health you bring to your people. And I believe that you bring more health with your community health workers than with so many high-tech that doesn't reach the population. And also, this approach in program, it's more in this, it's also scientific, it's implementation science. We always forgot that. People are focused on, let's go and do the next big toys that we can go and show and miss. Fancy. No. Let's go and do what brings health to the people near their house, near they live. And so if you go for great innovation, we need that. We need vaccine. I want to recall Hpv vaccine. Great innovation, great discovery, important, one of the major cancer, woman cancer, killing almost as much as maternal death. Those were sleeping in store, not used by the world during years. You brought it in a country like this one. We managed to vaccinate kids age 12 before having a sexual intercourse. 96% of our kids were vaccinated. Since then, and we have now age 12 to age 20, all the girls in this country, 93% of the girls are vaccinated regularly, every year. So this is thanks to our community health workers. So you have a high-tech, very expensive things there, sleeping in a cupboard that you cannot use because you neglect this low-tech. So low-tech are sometimes bringing more profit to the business world and more health to the people than this high-tech that doesn't reach the people.
Thank you. I think that's a provocative idea that maybe needs to be talked about a little bit more. But to skip to the very high tech, Dr. Dzobo, can you talk to us a little bit about the research that you're working on right now?
Okay. Thank you very much. I think I feel lucky because in the morning we were given 5 minutes, so now I can take 20 minutes to talk about my work. But okay. I work at the University of Cape Town and also at the ICGB, so I think you understand that I do a lot of research, not just one area kind of like, but perhaps I'll talk about 2 areas that I do my research on, and that is regenerative medicine and cancer. I think in the morning you heard a little bit about the work that we are doing, trying to induce differentiation of stem cells into different tissues or different types of cells. And in that work, I think if you look at Africa, we still lack the equipment, the infrastructure, and the knowledge to do stem cell research. It's a relatively new area, kind of like to us. So what you find is that for us to be able to do what we are doing, we have got partners in the US and in Japan that we work together with, especially in terms of getting equipment. Because when you talk of stem cell research, basically what you are doing is you are taking stem cells from their natural environment, which is the human body, and then you take them what we call in vitro outside. So for you to be able to maintain them in their right state, you have to provide the right environment, and that is expensive in itself. Like I said in the morning, for you to prevent stem cells from differentiating into unwanted cells, you have to add a lot of growth factors and other reagents. But since you heard a little bit about stem cells in the morning, I think I'll talk about the cancer research that we do. And we are not like other laboratories. As we focus on cancer stem cells, this area is very important to me because I've lost family members, I've lost friends to cancer. And sometimes you are just there hopeless and you wonder why this is happening, yet people are going for treatment. So what we now know is that, you see, what we call cancer is not just a lump of cancer. What we call cancer, these are different types of cells. But most importantly, they are what we call mother cells, kind of like these are called cancer stem cells. So we are focused on studying cancer stem cells with the hope that by understanding cancer stem cells, we are trying to hit or to kill the root of the cancer. So what we are doing at the moment is we are trying to come up with compounds from natural resources that can target cancer stem cells. Not only that, to also understand the behavior of the cancer stem cells. You can take cancer stem cells as like, take a tumor as a colony of bees. And the cancer stem cells are like the queen mother, kind of like. So you can use any type of insecticide to kill the bees outside. If you don't go inside and kill the queen mother or queen mothers, because there are so many, you are not going to succeed. The cancer will relapse, it will come back again, and probably the queen mothers are the reason why there is a resistance to drugs when it comes to cancer. So those are the two main areas that we focus on. There are some others that we might discuss some other time. Thank you.
Thank you. So this is exceedingly high-tech research.
Yes.
With what I would consider and assume is a pretty high-tech medical intervention at the end of it. Why do this here? And why do this in Africa? And how do you transmit this to African patients, to the average African patient?
Yeah. Okay. So if you look at data that is out there, you'll find that we are realizing that especially when it comes to cancer, personalized medicine is the best way to go. So what it means is that if you compare the different races, Caucasian, African, Asians, and so forth, we do have some differences. So it is important that scientists on the African continent also use either tissues or cells on the African continent to do this research, because most of the time, some of the medicine that comes from Europe or America, it might work on 10 or 20, 30% of your population, but the other population is left out. So you tend to have a lot of people dying from these diseases, although they are undergoing treatment. So it's important to do this kind of research on the African continent as well.
You mentioned a lot of collaborations that help you do this research. You're at UCT, which is arguably one of the most advanced institutes on the continent.
Yeah.
Anything in particular that's been most instrumental for you in terms of moving this work forward?
I'm actually leading a collaboration between the University of Cape Town, the University of Pretoria, and ICGB, because this is on the stem cell research, because we realize that because this field of research is very expensive, you can't go at it alone. So we realized that by pooling resources together, we'll be able to achieve much more. So we formed a collaboration, which we are still working on, and by coming together, we have been able to do quite a lot. As I sit here, I think we are working on 2 patents in terms of some of the biomaterials that we came up with that can induce differentiation of stem cells. So I think we are achieving a lot. Hopefully, by the time we meet in 2 years' time again at another NEF session, I'll be able to tell you that we do have 2 or 3 patents.
I hope so.
Yeah, sure.
Keep us posted. So work like this generates enormous amounts of data, and work like yours generates enormous amounts of data in the public sector. This seems to be one of, what I see, even in the popular press, to be one of the biggest issues around personalized medicine is this data security and privacy aspect. So, Genya, I turn to you. Since you've been looking at personalized medicine across the world, how are you seeing this issue of data privacy and security? Are you seeing anybody addressing it well? Things that might be replicable or good best practices that you see?
Thank you. And what we do at our new campus of the World Economic Forum in San Francisco is really look at the policy drivers and enabling the movement of emerging technologies through society and economies. And we're an international organization, and we thrive on public-private partnerships and bringing together through our multi-stakeholder platform those partnerships that can help to tackle some of these very pressing questions. Being in San Francisco, we are awash in the data community and also awash in many innovative ideas, and a lot of people come through our door of our center, which is just 1 year old, to talk about healthcare and all of the amazing technological innovations and research that they're doing, both the scientists and the technologists. And the challenge that we are facing when we think about, we call it precision medicine, but really the more targeted and personalized way of diagnosing and treating disease, is how to think about the idea of doing that, since we are a global institution, in different contexts. And in that case, when we think about precision medicine, we often think about it as a developed country kind of approach. Lots of fancy science coming out of fancy labs and generating very expensive things. And what we're trying to do is a reset on that as we develop our policy pilot program and look at how do you think about a precision medicine approach in low resource environments, for example. And what would it look like if we were to start to set those policies and enablers to move to that kind of approach to disease treatment and diagnosis? Data being the fundamental piece of this, and seeing that data are coming into this space. Precision medicine is really being enabled by massive amounts of data, particularly genomic data. So the questions are fundamental in any of our scoping exercises around how do we accelerate precision medicine. You've got to go back to the data. And how do you think about data in a variety of environments? So the collection and protection of data is probably the most common question or concern that I get no matter where I go in the world and start talking about precision medicine or healthcare. And so what we are identifying are new opportunities for thinking about how to comply with data policy, privacy and localization challenges in particular. And as data start to proliferate through, say, over 50 genomic sequencing initiatives now around the world in different countries, how do we protect that information but also enable it to be accessible for research and for development? And the best practices part of that question, I think, is very much open for debate. There's a lot of rules and regulations around that. And so we are looking at, with our cross-border data flows idea, how to enable the accessing of data where they reside. such that those data can remain protected either behind proprietary walls or national walls, and develop a policy playbook that enables us to work with distributed data systems. And I think this is particularly relevant as we look at things like H3 Africa, where we see a lot of this genomic information coming up in different countries with different data environments, and maybe places where it's not quite worked out yet. How we're going to get access to that information, bring that information into R&D pipelines. And so what we're really about with our center projects are looking at those policies and norms and standards and best practices and co-designing those with the scientists, with our industry, with governments, and trying to ensure that we are at the highest standard possible when it comes to dealing with data protection.
Actually, H3 Africa is an interesting example because that was originally funded using NIH money, correct? So public money for research, the data has to be public. Presumably this is personalized genomic information of individuals across Africa. Do you know anything about how that was dealt with?
We see a lot of this type of research being funded with public money, and absolutely correct in that that data, particularly depending on a country's policy, has to be publicly available. It's publicly funded. The challenge is, great, it's publicly available, but then you have a country that says, for my own reasons, I will not let that information about my citizens or my populations leave the country. So then what happens when you have these international collaborations that you want to do, or you have a small data set here and a small data set there, and you need to be able to facilitate in our mind, when we're thinking about this, the going to of data. Yes, it's available, but there are a changing landscape of data privacy restrictions coming through Europe, coming through China. And so we think a lot about how to work with the policymakers who are not quite ready to say, yeah, it's publicly available, but it's really sensitive data. So how do we deal with the complexities of making it available, but also protecting it? It's very tricky.
Yeah. Tracey, you must have a perspective on this. Coming from a private sector perspective, how do you, and please tell us what Babyl does first, and then how do you think about this collection and sharing of data with the public and private sectors?
Sure, thank you. Good afternoon, everybody. I feel rather privileged to be on this esteemed panel because I'm not a scientist. I spoke to my children this morning and said I'm on the Einstein panel. I'm probably the only person here that failed their GCS physics first time around. So I'm an implementer. So I take the science, the technology, and then hopefully turn that into something that is deliverable. And that's exactly what Babyl does in Rwanda. So Babyl Rwanda is part of Babylon Healthcare, which is a global healthcare organization that is taking new, innovative digital technology, and our mission is really simple and very easy. It's about putting affordable and accessible healthcare into the hands of everyone. And we're doing that in the UK. We've launched recently the first digital healthcare service called GP at Hand, delivering the first digital NHS service within the UK, and patients are joining us much faster than we ever imagined. Why Rwanda and why am I here today? I happily moved to Rwanda and live and work in Rwanda, and have been here for 2.5 years. I blame Dr. Agnes for being here. So when Dr. Agnes was the health minister, her and some of her colleagues saw the need for new and innovative technology, and for Rwanda to be a digital hub in that sense. So we're invited to come here. So what Babyl does in Rwanda is we have taken our system, which is a smartphone-based system, which basically is a doctor in your pocket. So it's very personalized, and it connects patients with doctors over a mobile platform. So the first challenge we had in Rwanda is that the smartphone penetration, whilst growing, is very low. So we took the technology and put it on a very basic feature phone, because, as I said, our mission is getting accessible and affordable healthcare, and that means to those, the majority of 85% of the population in Rwanda has access to a feature phone. We worked very closely in partnership with the Minister of ICT and the Minister of Health and her team, and also with the Rwandan Social Security Board. We worked very closely with all of those stakeholders to get a license because, again, there was no regulatory framework or license framework for a digital provider. We launched our service just over a year ago, about 16 months ago, and the results, I think, have almost speak for themselves, but I think what they speak for is the population of Rwanda, the government, the stakeholders, and how much they want to really digitalize and improve the health care of the nation. So we launched the service free. That was really for three distinct reasons. One was that we didn't really know whether putting the latest technology onto a feature phone was scalable and would be robust enough at scale. Secondly, so we wanted to test that. Secondly, we use all Rwandans and nurses and doctors who work out of our call center, and they're an amazing group of people, but they were used to delivering medicine wearing white coats and generally stethoscopes around their necks. So how do you train them and motivate them to deliver consultations over the phone, and how flexible and adaptable would they be? And thirdly, and even if the first two are a given, probably most importantly, would the population change their behavior? So would you be a subsistence farmer in the northern province in Rwanda, and where you're used to traveling maybe 10 kilometers to your nearest health post or health center, would you suddenly dial *811# and talk to a doctor over the phone? So that's why we ran the service free, and the results of that were pretty amazing, and actually even those of us involved in delivering it firsthand couldn't quite believe it. So to date, in just over a year, we have 850,000 users across Rwanda who are registered on our platform. Considering the population is 11.2 million and we don't treat under 16-year-olds, we're probably getting to about 30% of the population. Secondly, the technology, you always had teething problems, but it was scalable and it was able to deal with that number of registrations and users. And thirdly, the doctors and nurses speak for themselves. On our busiest days, we were delivering, when it was free, 3,500 consultations. So that was taking a lot of traffic and out of the existing system. If I fast track to date, the government is working with us. We are now part of the universal health coverage scheme here, which is called Mutual. We'll be delivering 350,000 consultations this year using digital technology, and another 100,000 to the Rama scheme, which is the sort of civil service scheme here. So almost 500,000 consultations are being funded here this year with a combination of ourselves, the government of Rwanda, who should be congratulated, and the Gates Foundation are also working very closely with us because they're very interested in how this technology could be scaled. So I think, I guess in summary, then I guess some of what we're talking about, which is personalized care, having a doctor in your pocket, prevention, actually getting to the base of the pyramid, delivering primary care to those hard-to-reach groups, those in very remote areas, again, is happening here. And the data that we're gathering, to your point, helps us predict where there might be high levels of malaria or where there's a need for young women around sexual and reproductive health. So I guess what I'd say, being an honorary Rwandese person living here, is that it's here and it's happening in Rwanda.
Fantastic. All right. I think we've got a lot of topics on the table for discussion. I would love to open it up to the audience for questions. Do we have any questions? And do we have a mic? Anyone? They're coming.
Okay, good afternoon. I want to ask, the informal sector is a disruptive and expansive environment that is oftentimes obscured And the arts and culture is a beautiful display of what unfolds in this sector. Innovation definitely is not lacking either. So the question is there a bridge or hybrid initiative unfolding to harness these vast resources that are squandered on the continent? And those of us who interact with this sector, is there anything that we can to work, is there anything out there to provide, for us to continue to provide an enabling environment to highlight such unusual talent and skill in this area?
Okay. Do you want to take, should we take a couple of questions? Do we have any others?
Thank you. By names of Israel Nyonshuti, a student from IPRC Kigali College of Technology. We are talking about the future of health, and as innovator or as someone in the field of technology, I understand the future of hospital. The reason why I'm a member of Innovation Club, and we are dealing on how we can hospitalize the hospital in terms of technology. But my problem is, in Innovation Club, we made some, we have some product made which help people to enable disabled people. Like we have Android-controlled wheelchair. We made blind guiding sticks, but after making those, they are kept in our showroom. And yet people need them. My question is it, why are they not being used? Is it because of low level of technology, or it's about government policy? So I want to know if it's, I'm asking what you can do to improve, or if it was not known so that we can do more as people in field of technology. Thank you.
Okay. Well, let's start with these two. So we have a question on the table about, I think, if I understood correctly, the confluence between the health sector, health and science and technology, and arts and culture. And another one about technologies that are getting developed but getting locked inside of labs. So anybody want to take a stab at one of these?
So the intersection of hard technology and the subject here, which is the future of health in Africa, I think heart can be very useful in preventive programs, to dialogue with the population, to inform the population, and to attract the population in changing behavior by using tools that please the population. That's what, even to adhere to treatment, and I think it's a tool of communication in the health sector. And I think it is used from the formal sector in heart as much as the informal sector. When our people are dancing Rwandan dance with Rwandan song that are promoting ICT or mutuelle de santé or fighting malaria or preventing HIV/AIDS, is using heart at the service of preventive and treatment program. Now I'm going to jump, I think, to the second question, the future of hospital. I think more than 80% of health problems are outside of hospital, and prevention also. So it should be taken holistically and not focus on hospital. But what to do with innovation that are sleeping in cupboards, it's not necessarily government policies, it's probably a business plan. And it's probably how you promote this innovation you have that can serve the people. They need to be informed. If you innovate and wait for the government to promote and do the business plan, I think they will sleep in a cupboard during long, long time.
Tracey, thank you very much.
Thank you. I guess a couple of points on both questions is that when I think about healthcare and when we were trying to get people to understand what babyl means, because it's a pretty meaningless word in many ways, then we used art and culture in terms of getting the message across. So we would do activation events in remote areas across the country. We would take actors and singers, and they would kind of rap, and they would use those skills, their art skills, their creativity, to get across a health message that people were going to listen to. Whereas if it's a pretty dry subject, if you try and just talk to people about that, that's often very difficult. But if you do it through art, creativity, music, then it's a much better way to get the message across. And one of my best moments was in a very remote part of Rwanda, where we had a stage and we had people singing and rapping about, when would you dial *811# and use a digital solution? And a very elderly lady got on stage with a goat under her arm coming to market, and told a story on stage about how she'd used babyl because she hadn't been feeling very well, and how she had a doctor straight away. So that, to me, was a real example of using art and creativity to get messages across. I guess to the second question is that innovation is hard. It's not easy, and you should never give up. So, how many artifacts are in the cupboards from innovators that never get used? And I can think about many times in Babel and Babylon where we've tried things and they haven't worked, and it's disheartening. But first of all, I'd say never give up, keep going. Secondly is that with innovation, you need to find a need. So innovation needs to fill a gap, and you need to find what that need is. And then you need to understand how you're going to fill that gap. And so Dr. Agnes's point, it's also about having things that are boring. I find it boring as an implementer because I want to get things done, but you have to come back to a business plan. But please don't give up, because some of those things that are in the cupboards now might come back in a year, 6 months' time, and may be the best thing that's ever happened. So keep trying.
Any other?
Okay, I think I understand the question, and also I understand what the Vice Chancellor, right, what she said. Because at some point we were in the same situation with, I think, the student. So we developed this experimental system that we came up with that can induce differentiation of stem cells into cartilage. But then the question was, what do? We didn't know what to do, because you find that universities, I'm not sure about innovation hubs, but universities have got a discovery culture, kind of like we discover stuff. But then after that, we don't know what to do with the stuff. So that's where we need to be in partnership, I think, with the medical industry, because they are more into innovation. So when we come together, we can take a discovery into a product that can be given to people or the market. But you have to be careful as well, like what was mentioned yesterday, that sometimes scientists at universities or maybe innovation hubs, they can discover solutions for no problem. So if you come up with your product that doesn't have a market, of course, it's going to sit in the warehouse. So, and when it comes to government, they're not just going to think about your discovery. That's like a personal glory, kind of like. But the government is looking at a holistic picture, like what she said, where they are saying, where are our priorities, kind of like. So, yeah, you have to look somewhere else, not to just blame the government. You have to look at trying to partner with the biomedical industry and see whether you can take it to the market.
Absolutely.
Yeah, and so the question might also arise as to why Rwanda for me, being on this panel. And indeed, Rwanda is a partner. The government of Rwanda is a partner at our center in San Francisco, our Center for the Fourth Industrial Revolution. And in this center, which is a sort of an outpost of the forum, we are looking at the policy drivers around technology adoption and acceleration. And in that space, one of the reasons that I'm here is to work with and learn from the stakeholder community about these kinds of innovations. And sometimes the technology, and we hear this a lot from governments, is far surpassing their ability to keep up with what does this mean, how does this get integrated into my planning, how do I build the skill sets that I need and the infrastructure that I need to enable a strategic move forward. And I think in healthcare, there are immediate challenges, and then there's sort of the long-term planning process. And I've been very impressed in meeting with hospital systems and with policymakers and entrepreneurs here in Rwanda about we have immediate challenges that must be dealt with, and cancer is one that is coming, but also the opportunity to think creatively about the gaps in policies and the policies that enable the innovation to happen and the adoption to occur. And I know, Tracey, babyl is, I think, billed as an AI-enabled platform. And so, what does that even mean? And how do you think about, as a policymaker, where does AI fit now in this whole space that I used to work in around healthcare? So this is what we're really about in our center in San Francisco, is working with governments, with industry, with civil society, academia, and thinking about the enabling policies. Just like we're testing technologies, we need to test the policies that can help drive these things forward. So that's part of the reason why I've been so excited to come to Rwanda and responding to, sometimes they're just not ready for the technology, or it hasn't been, you haven't really thought about how it integrates in or is supported by your strategic plan and your policies.
Just to complement this, you have innovation such as student academia, fund things. You have the business world who turn that in product, first partnership, that counts, but the product is still not health. You need implementation science to turn that product in health. And that's what I wanted to express when I told you about HPV vaccine, a great vaccine that were sleeping during years in store, not used because this amazing product was not transformed in health for the people. So you need to find those partnerships. And probably doing that from the start or continuously is another great innovation to bring the world.
Okay. So bringing sectors together is key. Totally easy, as we all know.
If I could just
please, Tracey.
add to what was said around artificial intelligence. So we've developed a digital solution in Rwanda, and again, we're now talking to the government with the Gates Foundation, and by the end of this year, we'll be running a pilot with a small number of community-based health workers who already have a system of SMS alerts and feeding into the national health database. We're actually going to be giving them an artificial intelligence tool, which will help them, we think, assist in earlier diagnosis of diseases, right as Dr. Agnes talked about earlier, right where people live, right at cell level. So if you can imagine that the way innovation is changing and the way world is changing is that eventually we can have community-based health workers essentially with a doctor's brain on a very simple and easy-to-use device.
Wow.
So the world is changing, and it's changing very fast, and even as an implementer, I really struggle to keep up.
Wow. That doesn't sound like a full employment program for doctors, does it?
The shortage is so huge that, go ahead. Go ahead.
That's the point. What it does do is it leaves the doctors to deal with the cases that they really, really need to deal with. So very often patients will walk 30 kilometers, queue all day at a district hospital when they really didn't need to be there. So if you can treat them at the base of the pyramid, give them good medicine, then actually it leaves the scarce resource of doctors and nurses to do what they're really trained to do.
And it's the task shifting that allows the developing world to bring quality care constantly to their people.
And what's interesting, the doctors and scientists are developing it. So we have 150 of them all sitting in a room, all really excited about doing it. Because every doctor wants to get the best medicine to the patients as fast as possible.
Okay. That is almost the most perfect summary, I think, of this entire panel. between Tracey and Dr. Binagwaho, this bottom line appears to be, have you improved health for people? It doesn't matter how you do it, what technology you use, what combination, the ultimate measure at the end of the day is, have you improved health? So I want to thank all of our panelists. Please join me in thanking all of our panelists today.
Thank you very much. Thank you to all panelists and moderator for doing a great job. Thank you. You may all regain your seats. So we're going to go into an exciting session, which is the final pitches of the CI2I session. Before we do that, we will need 5 minutes for the technical team to set up the stage properly. As the technical team comes forward to set up the stage, I'm going to give you 2 reminders. The first reminder is about the science theater play, which is taking place today. Yesterday, we made announcements about the science theater play, which is inspired by Richard Feynman, and the play is called The Principle of Uncertainty. So who said that science and art cannot go together? If there is anyone among you in this room, I invite you to go to the theater. The last opportunity for you to experience that is today at 5 p.m. And that's going to be in MH3 room. And the second reminder is with regards to the translation kits. So if any of you have taken the